Hello.
Hello, everyone. Welcome to Addressing Xylazine in Viral Hepatitis Care Settings. We'll just give it a couple minutes for everyone to come on through, and you can take a look in the chat, and if you'd like, introduce yourself.
Familiar faces, familiar names. We're glad you all are here.
I'll go ahead and just introduce this webinar real quick while we're having people continue to file in from the waiting room. So this is a Hepatitis Network for Education and Testing webinar. We'll talk a little bit more about what HepNet is as we kind of go through it. But in this webinar, we've got Dziko Singleton, who is a HepNet Leading with Lived Experience consultant, and I'll explain what that is as well as I go through the slides. And we've also got Dr. Andrew Klein, who's a volunteer at the Medical Reserve Corps and previously a physician at outpatient wound care centers. And they'll be discussing the increasing presence of xylazine in the drug supply and its impact on people who use drugs. And the panelists are going to discuss how they're addressing xylazine's health risks for people who use drugs in their respective care settings. And they'll share the latest findings, harm reduction strategies, and culturally responsive approaches to care that follow the lead of people directly impacted by xylazine use. So this is a really exciting webinar. I won't say it's an exciting topic per se, but I know it's something that we all care about. And I think as the discussion goes on, xylazine has been something that's been talked about in various settings for many, many years, but it's increasingly something that's on our radar as care providers and/or people with living expertise, lived experience, and other people who are invested in the wellness of people who use drugs. So with that said, I'll go ahead and just remind you that if you'd like to take a look at the chat, we've got a prompt for introducing yourself and getting acquainted. And I will go ahead and move into the webinar slides, and we'll just give a brief overview before turning it over to Dziko and Dr. Klein. So we are here with the Hepatitis Network for Education and Testing. My name is Cass Botts, and I'm the Coalition and Capacity Building Manager for the National Viral Hepatitis Roundtable. Joining me along with Dziko and Dr. Klein is my colleague Jasmine West at NASTAD. And we are the kind of co-managers of the Hepatitis Network for Education and Testing. The HepNet partnership team is made up of the National Alliance of State and Territorial AIDS Directors, NASTAD, my organization, National Viral Hepatitis Roundtable, NVHR, and the National Association for City and County Health Officials, which is NACHO. So if you're unfamiliar, you can check out our microsite at nastad.org/HepNet. And the Hepatitis Network for Education and Testing, just in brief, is an entity that really connects us all around viral hepatitis care and addressing health equity and racial justice in viral hepatitis care, specifically focused on people who use drugs. We provide technical assistance and training to the network members with a focus on Hep B and Hep C. And really just it's all about identifying and then addressing the unmet needs of people who use drugs in viral hepatitis care. Our network members are all of the individuals and organizations who make up HepNet. So anyone who has signed up for HepNet, and you'll get an opportunity to do that throughout this webinar if you haven't done so yet, are the HepNet network members, which kind of, according to this graphic, is kind of like the core base. But we've also got learning communities that we form out of the network membership. And we had our inaugural learning community last year on strengthening partnerships between institutions and community-based organizations. We've also got Leading with Lived Experience consultants. And so Dziko, who will be having this chat with Dr. Klein, is one of our Leading with Lived Experience consultants. And they have gone through a training curriculum to sort of develop technical assistance expertise to be able to facilitate the learning communities and provide TA to the learning community participants. And we also had training consultants. So Nick Boyles and Tina Reynolds are our training consultants who developed the curriculum that was given to the Leading with Lived Experience consultants. And so that's kind of the core makeup on top of the partner team of who and what HepNET is. Again, the aim is reducing inequities in viral hepatitis care among people who use drugs. So here's a little look at our HepNET membership dashboard. We've got 244 members at present. We launched the network last year. And the organizational types that are represented, we've got local health departments, state health departments, community hospitals, and SSPs that kind of like the core makeup of the membership. But we've also got folks from lots of other kinds of organizations and people who aren't affiliated with an organization but are just kind of a personal stakeholder, be it personal investment in equity for viral hepatitis care, maybe people with lived experience themselves. I went through the structure, but yeah, just that kind of core base at the bottom there is the 244 network members. And, at minimum, you're going to stay connected to things like these webinars, our newsletters, educational opportunities, resources, etc. And then there is opportunity for deeper engagement. If you be on the lookout for our announcement of our learning communities and can participate in those are kind of longer 5 to 6 month commitments that are focused on CA for really specific topics. There are our training consultants who I mentioned, that's Tina Reynolds and Nick Boyle. And for the training consultation that they developed and led online interactional training with integrated themes of inclusivity and meaningful engagement of people who use drugs, radical love, viewing lived experience as a subject matter expertise that can be, developed further as someone, makes that part of maybe their career or their professional development from the perspective of lived experience. And they also use the teacher-learner, learner-teacher relationship. So it's not kind of unidirectional where the teacher has the knowledge and they're going to give it to the learners, but it kind of is this bi-directional relationship where we're all teaching and learning from each other. These are our Leading with Lived Experience consultants. So we've got Jen Sharp, Dante Smith, and Dziko Singleton. And we had our learning community last year that was made up of participants from cohorts representing Idaho, Houston, Texas, and New Hampshire. For the learning communities, we worked on developing action plans that would build and strengthen partnerships in viral hepatitis and harm reduction programs in your jurisdiction. We worked on engaging with group discussions that provided case-based examples from the jurisdictional context. So each jurisdiction was really able to learn from each other and learn from both the similarities and differences of what they were experiencing in their jurisdictions. There was the technical assistance provision. So everyone participated in individual and group technical assistance sessions with peer-to-peer engagement, info sharing, and resources development. And then we really identified and explored relevant models and best practices for viral hepatitis services, specifically for people who inject drugs. So that's kind of how our learning communities have been structured, and we're going to continue them in the coming years of HepNET. And just a little bit on evaluation of the learning communities in case you think you might be interested in joining HepNET and or joining one of the upcoming learning communities. We had folks who said that their understanding of a shared purpose for the partnership in improving viral hepatitis care for people who inject drugs increased a lot as a result of the learning community. Also awareness of inequities in hepatitis care and awareness of intersectional identities that mean, the multiple ways that people who inject drugs are marginalized. All of these dimensions increased a lot for most of our participants of the learning communities. So that gives kind of an idea of what we go over and what you might, get out of participating in the learning communities. We also got some quotes from people who participate in learning communities. So the question was, how has your work or practice changed as a result? And someone said that awareness to widening testing strategies and opportunities for individuals who inject drugs and are currently experiencing homelessness was a way that their work or practice changed. Someone said, my work has not changed. We were already expanding HCV testing and mobile phlebotomy, but I now have resources in other states to contact to learn more about best practices. So really that kind of like inter-jurisdictional connection was what was of value for that respondent. And I intend to tackle some of our objectives in conjunction with our current syphilis outbreak response efforts. All right, so yeah, the post-cohort assessment for the learning community, how would you rate how each of the following items and how they have changed since participating in the learning community? We've got their organizational leadership's buy-in to partner. So that was kind of a mixed bag, increased a lot, increased a little, and no change. Organization's active engagement in the partnership increased a little. So I won't go through all of these because I know we want to get to the content, but you know, I think that the biggest increase in awareness of inequities and awareness of intersectional identity and multiple marginalization is important to note because that's really what we focus in on is health equity and racial justice and viral hepatitis care for our learning communities. And a few more quotes. The learning community inspired and renewed their passion for this work, along with tools to engage and grow community partnerships. They were able to see how unconscious bias was affecting their work and really loved the inclusivity and representativeness of the leadership. So again, you know, as part of HepNet, we want to be able to provide just educational opportunities like this webinar, but if you want to delve deeper, we just want you to be aware that there are these learning community opportunities that'll be available to kind of work more specifically on targeted goals and topics that are related to HepNet's core goals. All right, so we've also got some resources in case you're interested. The Unlocking HCV Care in Key Settings was a 2-day virtual convening, and you can see the summary report, the slides, and recordings at nasa.org/, that link there. We can share the link in the chat for anyone who wants access, but this was a convening on the key settings of FQHCs, correctional facilities, SSPs, and programs providing MOUD, in which we talked about implications for HCV care integration in those settings. So that was the HepNet overview, just to give everybody a chance to get acquainted with why we're here and putting on this webinar, and learn a little bit more about the context in which Dziko has been working with HepNet and providing technical assistance and facilitation for our members. Now we're going to turn it over to the actual content of the webinar, which is welcoming Dziko Singleton and Dr. Andrew Klein to discuss Xylazine in their care settings. So I will turn it over to my colleague Jasmine, who will facilitate this session.
Awesome, Cass. Thanks for that. Hi, everyone. Jasmine West, she, her pronouns. I'm a manager on NASA's hepatitis team. And Cass just gave the plug for everything HepNet, you know, all the good stuff that we're getting out of it, all the involvement we have from harm reduction folks and viral hepatitis services. So we're actually really glad to have Dziko Singleton and Dr. Andrew Klein on the line today. And I'm actually going to first start off with some introductions from them. So Dziko, tell us who you are, why you're here, what you're passionate about, and then we'll hand it over to Dr. Klein.
Hey, everybody. I appreciate you joining. My name is Dziko Singleton. I use she, her pronouns. I identify as a woman in abstinence-based recovery, and I'm also co-coordinator of the Comprehensive Harm Reduction Program here in Richmond, Virginia, along with my co-coordinator, Colin King. And I appreciate everybody coming to sit in for a minute.
And Dr. Klein?
Hi, I'm Andrew Klein. I was drafted into this because chair of the department here said to me once, "You do wound care. What do you know about Xylazine?" And I gave her a blank look, and I Googled it and I spelled it wrong. But now it turns out it's a thing and it's a real thing, and I knew nothing about it. So now I know a bit more, and we all do. So can I just jump in and explain what xylazine is and go from there?
Please, yes.
So what is it? It's a non-narcotic, non-opiate sedative and muscle relaxant, and it was prescribed, it is legally prescribed by veterinarians. It's used mostly for horses. It was designed in 1962 as an antihypertensive agent, but it was too strong. It just knocked out people's blood pressure. So they were desperate trying to find a use for it, and they found it was worked in large animals. And it's been very quietly been used there for a long time until about 20 years ago, it's popped up in Puerto Rico for the first time in street drugs. And then it kind of worked its way to the continental US, started off in Philadelphia and expanded everywhere. And it's now been in all 50 states. It's still not classified as a controlled substance by the federal government. A handful of states have done so, but it is still legal. It's to purchase. I admit that I went online to try to buy it to see what it was, and it cost like 20 bucks for a kilogram. So it's ridiculously cheap, and it's legal. So that's why it's being used. It's being added to street drugs because it's a lot cheaper than heroin and fentanyl. It's bulk, so it looks like you're buying something in volume, but it has its own problems and complications. When you first take it, it causes certain symptoms like a dry mouth and drowsiness, high blood pressure, high heart rate or tachycardia, and then immediately drops down to low blood pressure or hypertension, bradycardia, respiratory depression, cardiac arrhythmias, and maybe even a coma. So it has very strong CNS depression, respiratory depression, and it can cause cardiac arrest. Since it's not a narcotic, it doesn't respond to naloxone or Narcan. The antidote is being worked on desperately by people around the country, but right now there's nothing. It's still recommended if somebody does have an overdose that you give them naloxone because it's usually used in conjunction with the narcotics. And if you can reverse those effects, you might still be in a good enough position that you'll bring the person around. The most important thing from my standpoint is more of the chronic nature or the chronic wounds. I worked in wound care in an outpatient clinic, and the standard of care there is to have people come in every week. You look at the wound, you clean it, and you change the dressing based upon what the wound is doing, either improving or not. But we didn't have that luxury with this population. We had to kind of go to where they were, and that's why Dziko got involved and got me involved. And I'll explain to you what we've been doing, but I think she's just going to first go from here and explain what she is seeing on the streets, and then we'll go from how we've been trying to address this. Okay, Dziko?
Of course. Jazz, do you need to pop in?
I think we should do some level setting. So thank you for that, Dr. Klein. Cass, if we can next slide, please. Because Dziko and Dr. Klein are both based out of Richmond, Virginia. We do have this content warning where we are going to share some images of wounds on the next slide. So if you would like to step away, you can take your minute and then come back. So I'll give you a few seconds if you need to. But Cass, next slide. So we have one picture here and two. Dziko, if you want to elaborate on what these are and the actual images and clients in your clinic.
Sure. So about maybe 2.5 years ago, my colleague and I, Colin King and I, were starting to see wounds just like these at our outreach locations. And historically, trends have shown us that any different type of temperature change in the drug supply or with carceral instances will come down 95, right? So we began to see this, and we wondered if xylazine had finally entered the chat into Richmond, Virginia. We had already been watching Kensington, Pennsylvania. We had already been taking the temperature on places like New York and Baltimore, and we kind of knew that this is what was happening. We reached out for support from the Virginia Department of Health. And what we understood was that there was not a ton of research or study behind this in regard to drug user health, but we just weren't getting anything. It began to present more and more at the outreach sites. We run 4 different locations, and we're going to see about 350 people a week. And we knew this was something that we needed to try to get in front of, or at least try to have some better type of understanding about, because as I'm sure everyone on this call already understands, the stigma and judgment that comes from folks who use or inject drugs going into medical care facilities. I've experienced those stigmas and judgments, and our folks have come to depend on us, rely on us, and trust us. Trust is the most important word being used here, and they needed some support. We will be the first to let you know we aren't medical professionals, but we are harm reduction professionals. And we knew this is when we had to take it into our own hands to get some non-judgmental support. And that came in the form of our executive director, Karen Legato, who throws herself and this agency behind our program so much that she reached out to her good friend, Dr. Klein. And he was willing to come in and sit with us and develop this comprehensive wound care kit with us and became our in-house counsel. So when Dr. Klein tries to downplay the level of importance, his level of importance in creating this wound care kit, I have to remind him, he was absolutely 0.0 for us with this because we just didn't have any guidance or support. We reached out to several other SSPs, and thankfully nobody gate kept information. People were willing to talk about what was working for them and changes they were seeing. But things are different from place to place. We don't have oxygen tanks to take out to do outreach like some SSPs are doing out in Kensington. I wish we did. We don't. But what we're seeing are just like the pictures depicted here. Very real human beings who we care about, we have relationships with, who just did not know how to care for these wounds. And this is where the wound care kit came in. It might seem like a small thing to some people who are unfamiliar with this. This has been a game changer for us. And we're starting to see tangible results from this. And I think that one of the things that Dr. Klein impressed upon us the most was that our only interest is in keeping it clean and debris free. And people have been beautifully amazing about doing that. And we're seeing this in real time. So this is just something that our entire team feels passionate about. And it really is all due to the instruction and support we've received from Dr. Klein.
You take it to the next slide and talk about the wound care kits that y'all are doing.
Of course. So Colin and I attended a few Xylazine workshops at different conferences that we attended. And a couple of the things that was heavily talked about has been MetaHoney in zero form, like medical grade, expensive medical supplies. But this kit has been doable for us. We have a CHR or team associate, Joe Santiago, who has had wound care issues of his own from past experiences. And so he kind of took the lead with this. We see more and more people coming up and asking specifically for this wound care kit, as opposed to just regular first aid kits that we pass out during outreach. So this has been one of the most requested items that we distribute during outreach. I would love for Dr. Klein to talk a little bit about the solution that you see in the upper right-hand corner in the bottle. Hey, Shannon, I'm about to talk about that right now. So Dr. Klein, can you talk about Dakin's?
Sure. So Dakin's solution has been around a long, long time. It's essentially a bleach. It's very high alkalinity. And if you buy it, it's fairly expensive, but there are recipes that you can make, and we use half-strength Dakin's. And we wanted to use something that people were familiar with. Bleach is not an unknown concept to people who use drugs, to sterilizing equipment, things like that. So the team has been amazing. I gave them the recipe and told them how to make it, and they make it. They boil the water, they add the bleach, and we give it to people in a small spray, and it's very effective. It kills bacteria, viruses, fungi. It's pretty great. I mean, all of us grew up using hydrogen peroxide, which we now know is not so good. It kills all those things I talked about, but it's really effective at killing human cells also. It's called cytotoxic. So we do not use hydrogen peroxide. Our mothers lied, sorry. So we give everybody Dakins, because before this kit, around the country, the only treatment really was Xeroform gauze, which is a petrolatum gauze. And then people just said, wrap it, keep it clean, you're good to go. So we try to design a kit that the patients will determine what they need. We told them what to look for. First, want to keep it clean with the Dakins, and then if it's very wet, they will use certain things. If it's very dry, we'll use certain other things. If it's really, really wet, we'll use other things. So we kind of let them control what they're doing. Not like we were doing in a suburban outpatient wound care clinic where we told them what we were going to do. Here, we're kind of leaving it up to the people. And they've been very motivated because first it works, and if they don't do it, they're kind of in a lot of trouble. So that's the Dakin solution and a very long answer.
Yeah, thanks for that. And actually, Catherine put it in the chat for spelling and for folks to reference. But can we go to the next slide? Because, you know, a lot of us are grant funded. A lot of us are penny to penny, you know, by the fine print of our funder. So we actually broke it down here for the wound care kit costs. So do you want to dive into that and just talk about that cost benefit analysis?
This is a lot cheaper than anything you do in an outpatient wound clinic. A lot cheaper. But also we were able to, you know, buy things in bulk, buy things that are generic, make things that we need to make, and purchase the things that needed to be purchased, like the MetaHoney. But other than that, things are inexpensive, and it's a lot cheaper than going to the emergency room, a lot cheaper than having an amputation, and it's very effective.
It's been really effective because along with so many other items that we distribute during outreach. Like I said, people have been really vocal about asking for it. Can I get the big wound care kit? And people, like I said, trust. People come up to us time after time, week after week, to be like, hey, Dziko, look, you know, it's getting better, it's clean. And so we figure this is a very small cost to be able to support a population we super care about. And it's been easy to you know, to make these supplies. You know, I wish I had a better aggregate number to tell you how many we give out a week, but we're going to give, for like every fifth person that comes up to the table, we'll give out 3 different kits, because these wounds are presenting just that much. And I think once we started opening up the conversations, my colleague Colin has been really, really good about doing point in time surveys as far as, you know, have you ever heard of Xylazine? And it's always shocking to me, I think, when people say no, you know, because we know it's here. We know it's been in Richmond for however long. And we know that these wounds are presenting as a result of contact with Xylazine. So I feel really happy when people come and ask for the large wound care kits. And when they come and show us, you know, hey, I've been using my Dakins, I've been using the MetaHoney, you know, a friend of mine helped me change, you know, and if we have to, you know, we prop chairs up out at outreach and we will help people dress their wounds, clean their bandages. So just the empowerment that comes behind, you know, these wound care kits have been just a really big deal for our team.
Just as an aside, it's really important to tell people when to seek help. You know, if they're doing everything correctly and still the wound is going south, you have to say it's time. If it's obviously infected, if there's a rim of redness or erythema around it, which is a sign of cellulitis, it's time to get care. If you're seeing deeper structures like muscle, tendon, bone, you need help. If this turns gangrenous, you know, it's black, has no blood supply, things like that. That said, since Dziko started distributing these kits, she's not aware really of any emergency room visits. So I think if you can jump on these wounds early, you might prevent these from progressing. These can be used for any kind of wounds for people who are, you know, who in need. It's not specific to Xylazine, but the prevalence of wounds in Xylazine patients is like 38% compared to people who use drugs without xylazine is like 7%. So it's profoundly higher in xylazine. The belief is that this causes severe vasoconstriction, and the blood vessels contract. There's no blood supply to the wounds, and that's why you saw that one person's wound look black. And it doesn't have to be in the location of the injection. The same way the drug works systemically to cause the CNS depression, respiratory depression, it all causes vasoconstriction globally. So you don't have to inject in that spot where you get a wound. Okay, good to know.
Yeah, we're seeing people who tell us that, they may snort their drugs, and we know that these wounds can still appear. And I'm glad you gave that disclaimer. We let folks know we are not medical care professionals. We encourage people to seek professional medical help. But, we'll also have this as well. We're not saying that this totally X's out the importance of expert medical care. I'm not a doctor. I'm the first one who will tell you that, but, we have this as a support. So I'm glad you mentioned that, Dr. Klein.
Yeah, you're also giving these out with the wound care instructions, which are now on this slide here. We have some questions coming through, but real quick, do you want to talk about the instructions that you're handing out, and then we can open it up for the Q&A?
Sure, I can really quick. I think our goal was to not have this full of medical jargon because I'm not a doctor. And, we didn't want to, make people hesitant about, these steps when we know that this can be super non-problematic to use. So Dr. Klein gave us the instructions, and we were very careful about verbiage and just making sure it wasn't too wordy and long. So Dr. Klein, you want to speak to the instructions some and how we came about with these?
Yeah, I mean, we just explained to them how to keep this clean. And in wound care, the wound ideally is just not too dry and not too wet. I used to tell patients it's kind of like the Goldilocks thing. It has to be just right. Again, our mothers lied. They said it has to have a scab, has to be dry, it needs air. None of that's really true. It has to be just the right amount of moisture and not too much. So that was our thinking behind the different kind of dressings once we had the wound clean. But then we told people that if you're doing everything right, you're doing all the steps we talked about, and the pain is getting worse, or the redness is expanding, and it's getting infected, obviously, with pus and things like that. If you have a fever of unknown cause, as I said, if you have exposed deeper structures, and if it really starts to smell bad, or as it says, stinky, not a medical term, I admit that. But if we have that, then we tell people it's time to seek care. But I asked Dziko, are people going to the emergency room? She said, as far as she knows, that since we started this, people have not had to, which is pretty nice. So this isn't magic, it's just basic wound care, but it's being done, at everybody's own level and based upon their own needs.
Yeah, this is great. Thank you both. We actually have questions coming through, so I think we can stop sharing slides. Let's open it up. You all are the experts here, so I'm just going to read some that came through, starting with, are these kits specific to xylazine wounds? Or are you also using them for other wounds?
These were created in response to the xylazine wounds that we were seeing. We already had another first aid type kit that we were using that everybody asked for, I think for just very small wounds. But yeah, with the presence of xylazine showing up, they were presenting such aggressive wounds. This is like primarily what we've been using them for. I'm sure they could just be used for first aid kits too, but this was in response to the xylazine wounds we were seeing.
Right, and Anjanette here wants some clarification. Can you repeat the use of bleach instead of hydrogen peroxide?
It is not as cytotoxic. It doesn't kill human cells as much as hydrogen peroxide does. Okay.
All right, we got folks also asking about the availability and usefulness of xylazine test strips. So we knew this was a question that was coming.
Yeah, that's a really good question. I'm going to give you my personal opinion. A while ago, I just started to think that these test strips were becoming obsolete because what we knew was that people were saying that it was they were testing positive for everything, right? For xylazine, for fentanyl. We had somebody tell us the other night that when she tested came back positive, but she was like, well, Dziko, what am I supposed to do? Like, I just spent $20 on it. So I think just the thing that we just try to continually reiterate is to go slow and try not to use alone. That's all we can do. I know it's going to show up positive. We know that. We still give out a ton of test strips every week. So to me, that's empowerment. People want to know. And I think that if we just, have to give that disclaimer, not to use alone and to go slow, because I don't want to feel like it's obsolete, but that was my thinking a long time ago.
Great, thanks for that. Let's see here. So what information do medical care professionals have in emergency rooms about the impact of xylazine?
Very often they have no idea what's anybody's on. They can test for everything. We were talking to the medical director in Charlottesville, and he said every kid who comes in, they have no idea what they're taking, and they don't know. And all they can do is try to treat and try to reverse things as well as you can. But as it stands right now, there's no way to reverse the effects of xylazine. You can reverse the effects of the other drugs, so it's kind of a moot point. They might say, I need naloxone, and that didn't work, and I give it again in 10 minutes. And by then, hopefully they've bought time, because the xylazine has a fairly short half-life, so it might really knock you out, but you should start coming around pretty quickly, like within a half an hour to an hour, if you can just buy time. So they're aware of it, but there's not much they can do about it. Okay.
Lindsay here is mentioning, with the restrictions placed on purchasing veterinarian medications and supplies since June 2023, what and where is the source of xylazine? Is it on the black market, foreign countries, or other substances laced with xylazine, or is this injected separate from other substances?
Well, we were having a conversation during outreach one day, and I went on Amazon, and it was on Amazon. So we checked again about a month ago. I don't see it anymore, but I have no idea how people are sourcing this. I just don't have any idea, but it was on Amazon, and there were several different sellers who you could buy whatever quantity. So I really don't know how to answer that. I don't know, what makes your drug supply illicit or tainted. I don't know. I don't know how to speak to that.
I believe most of it does come from China, but I don't know how it enters the, to the pipeline. I really don't.
This is a loaded question for sure. I also see a hand up from Nick if you want to chime in.
Yeah, I put a question there, but mostly, from what we found out anecdotally, that it's not happening from the border side. Like that, it happens once it hits the United States, at least. And as far as we've gone back, that's what we've found. So if anybody has any evidence that that's different, that would be amazing. But most of the people that we've talked to that are as close as you can get to that area are telling us that it's done stateside, not at the over the border. If there's something against that, I would love to hear that.
Yeah, maybe this is something too we can take offline and respond as we post the recording and follow up. Let's see here. We have a question. Why and is Neosporin advised against?
The neomycin in it tends to cause more reaction. People have more reactions to the neomycin than benefit from the antibiotic ointment. So we try to use other things if we can, if we really need an antibiotic ointment. I mean, most dermatologists have gotten away from it completely. So if they just do a biopsy, they just use Vaseline petroleum jelly. We have changed ours a little bit to use a triple antibiotic ointment if it looks like it's infected. But neomycin is just not a first-line drug anymore. Okay. There's more reaction than benefit.
Shout out to Catherine in the chat. Philadelphia's wound care community worked together to create 35 recommendations across 12 topic areas. And so they dropped a resource in the chat for folks to access. But continuing on our question train, we have a question from Colin. So how do you address people that are reticent about going to get medical care in an emergency room? And how is this affecting substance use treatment process?
That's a good question, Colin. And I think it varies from conversation to conversation. Yeah, you know, a lot of our folks aren't all that crazy about going
Hey,
into
Joe. Yeah, I need, yeah.
about going into certain settings because of the aforementioned stigma and judgment. And so when people come to us and talk to us about these things, like I say, first and foremost, you know, we always reiterate that we aren't medical care professionals. And then we start there. I think that when the wound care topic comes up and people take these wound care kits, or we help show them how to do them the first time, I think that starts the empowerment phase. And so thankfully, you know, after that, more often than not, we have people who come back and say, hey, I'm ready to do something different. So whether that means that someone who might have tested positive for Hep C comes back and says, hey, I want to start treatment, that's a win. That's recovery to me. It is recovery. Anytime you lessen a riskier behavior, you take charge of your own holistic health. So, you know, these conversations change from person to person, situation to situation, but more often than not, our folks have been really, really good about just being proactive for their health, for showing up to harm reduction, for bringing, you know, used syringes back, for getting Narcan for themselves and their neighbors. You know, it's just, there's no blueprint for this. But luckily we've seen some successes and some challenges as well. So I hope that answers your question, Colin.
We have someone here who's a Hep C outreach worker and does about 3 days of outreach a week, performs Hep C testing and education, and sees wounds all the time. So do you have any insight about how they could, you know, get this wound care kit? It's actually never been heard of. Or how to connect with even clinicians in the area so they have this unique, you know, partnership between clinic and physician.
Dr. Klein, you want to take that one?
Well, Dziko will provide, I think she's put it on so it is available that anybody can make up. I would recommend you reach out to somebody at a local wound clinic and say, I just need somebody to help me. This is what they're doing, and can you just kind of guide us through this, the best way to get these equipment, how to make this stuff, how to, you know, that sort of stuff. It's not that difficult. It just takes Dziko.
Right, Dziko. But also, I think Cass wants to chime in too.
No, I was just reminding for anyone who may have come later, there are slides that have the information about the contents of the wound care kit that will be made available.
Okay, thanks, Cass. All right, so for some folks who are, you know, on the line and maybe not familiar with the wound images that had been shared, can you clarify there was a red one that was on the left, you know, and one that was on the right was kind of maybe black and crusty. Which one is in the process of healing? Like, what does that process look like?
The red one was gorgeous. Okay, that was a nice, healthy base. It's called granulation tissue. That's nice, healthy tissue. The other one needed to be cleaned up. Okay. And if you come to a wound clinic, it will get debrided. That means you put numbing medicine on and you scrape it off. Well, we don't have that luxury on the street. So what we try to do is do the best we can by keeping it clean, by using a proper dressing, and to help it debride itself by changing the dressings. Very often, if it's a goopy thing, you put something on to dry it. As you take it off, dead tissue will come off, and hopefully over time, it'll start looking pretty like the other one did. Okay. So granulation tissue, the red stuff is your goal. Okay.
Thanks for that. All right, so what advice do you have for areas that haven't yet seen xylazine in the drug supply? What can they do to be prepared?
Oh, gosh.
Right?
Gosh. I think with the first two that Colin and I suspected that we were seeing, we started, passing out xylazine test strips along with the fentanyl test strips. Historically, this is what happens, right? If it shows up in some regional area, any neighboring area, I think that you can expect to see these things. We were not prepared for this. There was such a huge influx. Colin and I were saying that, I think somebody mentioned to us, oh, this looks like crocodile or whatever. I had no idea what we were seeing. And then I think just upon our own reading in our own times, just trying to keep the pulse on some things that were happening, we knew this was coming. And people did not know what we were talking about, but people trust us. There's that word again. And so, when we were making the offering of xylazine test strips along with the fentanyl test strips, okay, I don't know what that is, but I'll take it anyway. And so then when it really, really hit, thankfully, more people were coming up to us like, hey, we're seeing it. My dope had this weird smell. It turned this other color, so, I don't know what people are using to cut drugs now, but, we heavily rely on conversations we have on the street, and just whatever education we can offer. So just prepare yourselves for it, I guess, get some xylazine test strips, attend these webinars. There's a ton of really great information by some really amazing grassroots SSPs that our whole team, we watch religiously on the weekends in our own time. So, just guard yourself the best way you can so you can support your folks.
And they might not know that it's in their drug supply, but if you ask them, and if their high is not quite as high as it was before, and it seems to last a lot longer, that's kind of a hint that it's probably in it, because it just knocks them out a lot longer.
Yeah, I just put a question in the chat too, are folks seeing xylazine in their jurisdictions, just to kind of get a pulse check, but feel free to put in your response. I see that Tina has their hand up. Go for it, Tina.
Hi, everyone. Thank you so much, Dziko. It's so good to see you, and powerful as usual. Thank you, Dr. Klein. And I want to go back to the trust. You've said it several times. I've not counted, but I think that you've also mentioned your conversations you're having with your people in the community. Drug selling and drug use is just as part of the community as anything else. And I think that one of the important things is to try to advise our drug sellers so our people know what questions to ask them if they're cutting their drugs with xylazine, if they're buying it, online or in the dark, on the dark web. I think that it's phenomenal to have these conversations and include drug sellers in this as well, because I don't think drug sellers want their people to get sick. They're in business. And, it's not like it used to be back in the day, but, we're talking about people who are not knowledgeable. And so I just want to commend you on that in informing your community about the possibility of asking these questions of the people they buy drugs from.
Tina, I appreciate you saying that. I have not had any conversations too much lately with, I don't know, maybe I have, I don't know. But we have had people come up to the table and say, hey, can I have some test strips? I want to test this before I put this out. That happens, and we also have some people who say, I don't need any strips. I trust my guy and da-da-da-da-da. And we say, we'll just take them anyway, just to have, just for a chuckle or whatever. So, we have non-participants who come to the sites, to our different locations, parents, people from around the way, and they come and get these supplies. So, I have to hold on to that and just hope that, people are being proactive in either their selling or their usage, or just making sure their neighbors have these supplies on hand if they need them.
Wonderful. And one other thing, oxygen. Has anyone talked about the impact of oxygen on overdose with xylazine?
So the program that we talked to up in Kensington, I can't remember which one. We've spoken with several. They do have oxygen tanks that they take out for outreach, and this is something that Colin King and I have talked about a lot. We wish, we had the funding to support initiatives like that, and we just don't. But I've seen a ton of the programs up in Pennsylvania say that they do take oxygen out to their outreach.
Thank you both again.
Of course.
For that, Tina. We have about 9 minutes left. There's still some questions coming through. So I want to make sure that we get to those. So let me see here. Are there any research or thoughts on certain substances increasing the severity of wounds when used with xylazine?
Can you repeat the question, please?
Yes. Any research or thoughts on certain substances increasing the severity of the wounds when used with xylazine?
Not to my knowledge, no. I mean, it's not like these are pure substances. So when we say something is a bad wound and we blame it on xylazine, there might very well be other things in the drug that we're not aware of. But no, I'm not aware of anything like that. I think anything that would cause vasoconstriction, and it's in the clonidine family. So, I mean, if clonidine is in it also, that would be like a double dose. So that's all I know.
Some folks are chiming in the chat box where they are seeing a significant amount of wounds. Some folks are saying, not yet. So it's good that we answered the be prepared question. Suggestion that would be great to compile a resource around xylazine test strip education and wound care. So maybe we'll plant that for a future HepNET resource. But I think too, just back to Tina's point of trust, y'all have mentioned trust. This is a very unique partnership. There's also somebody that chimed into the chat box. In Roanoke, Virginia Harm Reduction Coalition started a pilot wound care clinic with, a family medicine practice. So can y'all go back to basics? How did you establish this partnership, establish this relationship of trust? Because I do think that's where a lot of people need to start.
Trust with our program participants or with the illustrious Dr. Klein?
I feel like both and, right?
So yeah, that's a good question. Like I said, thankfully, this partnership with Dr. Klein is all thanks to Karen Legato, my big boss. Because we're such a small agency, and CHR is such a, outreach driven program. We have the luxury of being able to enjoy open door talks with her. And when we just weren't getting any support and instruction, we trusted our executive director with this, and she trusted Dr. Klein's expertise, and he just made himself fully available. And like I said before, he likes to downplay this, but he's busy too. We got to meet with him in person every single Friday until we hammered out all these details when we were telling him what we were seeing, and I have to admit, I think we had some trepidation before this initial encounter, doctors sometimes, I don't know, we just had some trepidation, and any hesitancy that we had in the beginning was quickly replaced with trust. We trusted his instruction and his support. And he was super in touch with us, like that we had phone calls, virtual meetings, that trust just grew and grew. And so that translated to the trust that our program participants have for us. We know our people, we know them. I grew up with so many of the people who are on our program. Colin was here in the beginning when this program first started. People trust Colin, people trust that we will be at our locations from 12 p.m. to 3 p.m. And so I think that when you ask about people's kids and, remember their birthdays and remember that they like this particular granola bar and not the one with nut, trust. And these just seem like such small things, but anybody in harm reduction knows. And on this call, period, because I think if you're on this call, you provide some type of service to a community and a population that's been extremely marginalized and left out of conversations. And this opens up dialogue. And so that's where all this trust comes from. And it might come from people you may not ever have the chance to see. I wish Dr. Klein could come out with us to one of our bigger sites, but thankfully he's entrusted us with what he knows and we take that out. So it's a comprehensive partnership that's really based on trust, and I don't want to say trust so much that it sounds cliche and trite, but if you work in these fields and in these spaces, trust is paramount.
But it goes both ways. I mean, I obviously trust Dziko and her team to do what we've talked about, to get the kits right, to make the Dakin solution correctly, to distribute it, and to call with questions. Because doctors worry. We worry about people if you're treating them and you worry if they're not doing well, and you want to make sure that things are progressing and not going the wrong way. So it works both ways. So we trust each other on this too.
Absolutely.
Yeah, that's amazing. And that's why y'all are here to share out with everybody, right? So I feel like in closing, words of wisdom or last pieces of advice, and it's just until next time.
I'd say just be prepared. If you haven't seen it in your community, you're going to see it in your community. If you start noticing wounds that you go, whoa, we haven't seen this before, just realize there are not that many wounds in heroin and fentanyl wounds. We used to see them, but these are horrific wounds. I mean, these a lot of times would end in amputation. These were just big, bad things. So if you start seeing it, you say, okay, let's get ahead of this and start getting treatment out there ahead of the game. And hopefully you can head this off with the pass.
I think I might say, if you work in these spaces, keep your finger on the pulse of what's going on, talk to program participants, talk to your patients, consumers, whatever verbiage you use, and just continue that trust that people have. It takes a lot for folks to walk up to that table and say, hey, I need some help with this, or I need a box of Narcan or whatever. That takes a huge amount of trust. And I don't think people should gloss over that. I say it all the time. I don't know how willing I would be to go up to some random folks at a van with a table set out in the middle of my community to get supplies. And that's where the trust starts, when people first walk up and say, hey, I heard y'all have some clean syringes. That's where the trust starts. And you can do beautiful work off of that small amount of trust.
Yeah. Dr. Klein, thank you. Dziko, thank you.
Pleasure.
Virtual round of applause. I'm going to hand it over to Cass for a brief closeout.
Yeah, thank you so much, Dziko, Dr. Klein. This was really, really good conversation. And just wanted to plug, if you're interested in furthering this conversation or some of the other stuff that we highlighted, we're really focused on with HepNet, be sure to join our membership. I put a link in the chat there for our sign up form if you haven't already signed up. Thank you everyone so much for participating, for all of your really great questions. This was engaging, and I think we all probably learned a lot from each other, as well as Dziko and Dr. Klein. So thanks everybody.
Thank you.
Thanks all. See ya.
Thank you.
Everyone.